Thank you. We have looked at major trials which are going on and which have seen the results that we have seen and how it has put ranibizumab or anti-VEGFs at the front line of treatment in managing diabetic retinopathy. I'll go back and look at Amitabh Bachchan, as Dr. Purnima said, of that's lasers in diabetic retinopathy, and see where it does actually fit into our practice and uh, see the results that come up with it. Okay, lasers in diabetic retinopathy can broadly be classified into two categories: pan-retinal photocoagulation for PDR, which is and macular lasers for diabetic macular edema. One which is an established, and the other which is being challenged by anti-VEGFs today. Proliferative diabetic retinopathy, the role of laser is well documented, well established by the DRS study. They describe the high-risk PDR criteria as NVD greater than 1 disc diameter or any NVD with vitreous hemorrhage, wherein definitive pan-retinal photocoagulation is needed. And the DRS study did show that patients who had undergone pan-retinal photocoagulation, the risk of severe vision loss did go down significantly by about 50% in such cases. But in current scenario, the treatment has extended further. We don't only wait for high-risk categories of high-risk PDR. We even plan and do PDR with non-high-risk criteria. They have now studies from ETDRS studies have shown that they still do benefit, or patients even with severe NPDR, wherein especially in India where we feel there is a poor follow-up compliance, or before cataract surgery, or in patients with renal disease or pregnancy, we have level 2 evidence of supporting pan-retinal photocoagulation in these cases also. Now looking at macular lasers for diabetic macular edema, which is a more controversial thing now. The gold standard, as Dr. Purnima looked at the ETDRS criteria, which described the role of macular laser in macular edema, gave us the criteria of focal laser, grid laser, how to go about it, what intensity burns to use, where the microaneurysms to treat. And it gave us guidelines wherein it said that good macular focal or grid photocoagulation can reduce the risk of moderate vision loss by about 50% in patients with CSME as they defined it on ETDRS. However, 17% of eyes with baseline vision of worse than 20/40 experience moderate amount of visual improvement. That was the reason that people started moving towards anti-VEGF, wherein the aim was to achieve some form of visual improvement. And in this phase, we then had a lot of other options which started coming in. We saw the number of trials that have been happening, looking at various options which could compete with laser, give us a better visual outcome. And such kind of trials, so is there still need for better? Has the laser lost its charm? Has the laser ended its life in cases of diabetic macular edema? If you look at trials, it seems yes, laser is out. But then you look at the trial more closely, even the rise and ride data showed that in patients with rise and ride, about the laser arm also showed about 3-line gain in visual acuity in 40% about the patient at 36-month interval. They also showed that patients from the sham group showed about that had received laser but no anti-VEGF also showed improvement, and also in arms wherein only ranibizumab was used, laser was used as a rescue treatment. So herein also the trial organizers knew that laser has a role. We need to keep laser as an arm in terms of rescue or as an alternative. So no doubt laser works. Looking at the visual stability, loss of less than 3 lines. Even patients who were being treated with anti-VEGF showed loss of lines. So it's not that anti-VEGF patients cannot fail. So anti-VEGF does also have a problem. There also the vision can drop down. Even after multiple injections, 40% of patients in the laser needed a rescue treatment in the laser in the anti-VEGF arm, in the ranibizumab arm. So when anti-VEGFs fail, laser come to rescue here. Other problems with anti-VEGFs, the ocular adverse events, the systemic adverse events are also something that we need to keep in mind. The risk of multiple injection increasing the risk of endophthalmitis, increasing the risk of vitreous hemorrhage, risk of myocardial infarction, stroke. There are also possible adverse events that we need to keep in mind when we are talking about multiple anti-VEGF injections. And then the financial burden to the patient. This was one study which showed that comparing the patient with combination versus laser, per patient amount spent was about 3.56 lakhs more than the patient who was only on laser. This is the kind of burden this is a Western derived study, study which was done in dollars. India it may be a little less, but still 3.56 lakhs is a significant amount of difference when it comes to cost. Plus the limitations of anti-VEGF. They have no effect on macular hypoxia. You need multiple injections. Not all patients gain vision. Some people do lose vision. Side effects are low but not zero. So herein comes the role of combination therapy, wherein laser is being used not as a primary sole treatment alone, but very often as a combination treatment. We combine it with ranibizumab in cases with deferred laser also and prompt laser also, showed a significant improvement in visual acuity over a long-term period of time. This is important for us in Indian scenario wherein all our patients cannot afford monthly injections for a very long period of time. Laser do have a role in this kind of a setup. A patient like this who has had already received three anti-VEGFs, NPDR with focal edema, shows clear-cut demarcated microaneurysms well off the center of the fovea where there is no risk. There is no harm in giving focal laser to these areas, reduce the leakage from these microaneurysms, and patient can have good visual outcomes with a combination therapy. Or such kind of a patient who have just about center involving macular edema or non-center involving macular edema with clear-cut leaks away from fovea, keeping a safe distance. You can keep a distance of about 500 to 700 microns away from the center of the fovea and safely do focal laser in these areas. It is not working as a standalone, I agree, because of its various problems. Patients have shown some drop in vision wherein laser has been used as a standalone treatment because of scotomas that can come up. There are different techniques of laser being used by everybody. There is no standardization. At times one is not very well trained to do focal laser. You're not able to properly localize the microaneurysm, so laser fail there and variable the intensity of the burn be given by a lot of people. So we have had areas wherein lasers have not worked, but that doesn't mean as a combination therapy it has lost its way, and it definitely has a way in there. So to summarize, laser treatment for PDR, there is no debate. For DME, still a valid treatment in specific situations as focal areas of edema with leaking microaneurysms away from fovea, as a second line or a rescue treatment. And patients definitely with PDR and CSM, you need to combine focals with PRP to achieve a good result. You have certain modifications which have come up with laser treatment such as Navilas, sub-threshold laser to help us out to reduce the size of scotomas and to give a better outcome. So this is not a case of one or another. Every patient is different and we need to really look at combination therapy when it comes to treating such patients. Thank you.
Thank you, Ritesh.